Okay, so I'm going to go over chapter 62, which is the muscular skeletal system. And we'll start by just going down through the bones. You don't need to know the bone anatomy for the specific test, but it's good just so that you have an idea of what you're talking about. All right, so first part are bones. The function of our bones, of course, is to provide support and protection to vital organs. It also stores your minerals, so your calcium phosphate, and helps with the red blood cell production. Serves as a point of attachment for muscles, and hematopoietic tissue, which is the making of our blood cells. So our um, function is support. All right. Our function is support, protection, and then these are all common sense if you think about them. Protects, um, hematopoietic. Make sure I'm pulling that right. POI. Oh, poietin. Cells, and then calcium, and then phosphate. All right, so again, it serves to support, protect the vital organs. It makes red blood cells, and basically we're just talking about making red blood cells. But calcium and phosphorus. So it serves as mineral storage, and then of course the point of attachment for muscles. And as we know, muscles are attached to bones by tendons, and we'll hit on that in a second. All right, so let's start off by talking about the actual bone structure for a second. You have your diaphysis, and this is a long bone. You have different type of bones. You have short bones, long bones, flat bones, and irregular bones. But we're using a long bone here. So, anyways, you have spongy bone. Spongy bone, uh, and I'm going to say spongy bone, but the other proper word, calculus, I'm trying to spell that correctly. No, I spelled that all types of bone. Sorry. Cancellulus. And I mean, again, we use spongy bone so often. But anyways, so spongy bone, and that helps to decrease the amount of weight. It also, we have spongy and we have compact bone. And a lot of the spongy bone is going to be where you have your marrow at. You're also going to have your growth plates in there too. All right, so the before I get into the actual cell structure, the this is our diaphysis, and this is our, is that off the screen? No. Epiphysis. And then of course you have a flaring here, and I'll just write it down here. And that is going to be your metaphysis. So these are going to be at both ends. So you're going to have these at both ends. You're going to have your meta at both ends. Meta is just where it flares out. Your diaphysis is the long part, and then your epiphysis. But the epi is going to be at the top and the bottom of the bone. You're also going to have a lining of it, and a lining, you're going to have an inside lining and an outside lining, which things attached to. The perineum is your fibrous connective tissue. It attaches by collagen, tendons attached to it, blood vessels go through it. It's not or on the inner surface. All right. So you have your endo and your peri, and just kind of like how you have your pleura and your visceral, but perio. I'm making a conscious effort to not spell things incorrectly. Peristome. All right, that's going to be on the outside. Okay, so the outside is pretty much where everything attaches to. Okay, the medullary cavity. So this is going to have your red or yellow marrow. In children, especially in children or younger adults, you're going to have red, but as you get older, it turns into adipose, so it becomes yellow marrow at that point. And that's, of course, where all of our cells start from. So the okay, so you have up here, you're going to have your cartilage. And that's basically where bone-on-bone meet is called articulation. So that's anywhere where 2 points meet like that. And of course, where 2 points meet, hopefully you still have cartilage there. Hyaline cartilage is the most prevalent cartilage we have in our body. We also have elastin and fibrous cartilage. The elastin cartilage is like something like that you can flail around your ears, really flexible. The hyaline cartilage you'll see especially on articulating surfaces, but you're going to see it all over the place. And your fibrous cartilage is extremely hard. You might see it in shock absorbers, so in between your discs, right? So it's extremely hard, very fibrous, as the word might suggest. So your cartilage is going to be up here. You should also have synovial joints. Synovial joints, let's see. So synovial joints, and there's tons of different joints, but I'm just going to talk about this briefly because it's not going to be, and let's pretend this is your knee, a well-drawn picture of your knee. Of course, you're going to have your meniscus in here, which is what everybody always cares. But your synovial joint is a capsule, not to be confused with bursa, but your synovial joint is a capsule. You're going to have nerves and blood going into that synovial joint, but basically its whole point is to lubricate and make sure that you're having a gliding surface. So that would be like your synovial joint, like in your knee. The bursa sacs, they hold synovial fluid, but it's not quite the same because a bursa sac, for instance, ball and socket joints, like your shoulder. Your shoulder, you have a bursa up here, and basically what it does is it's a sac of fluid to provide some cushioning. So anything that's really, really mobile, whether it be your hip, your arm. That's why we have so many issues, because the more mobile you are, the more prone to injuries you are, and the more that can go wrong. So those bursa sacs are found a lot in very mobile joints, so joints that can move in multiple directions. So that's bursa, and synovial is going to cover the joint itself. Bursa is not covering a joint; it's in between a joint. All right. So if I were to draw, let's say this is the socket of your arm bone. Let me just pull this apart. Your bursa sac. So this is your arm, your humerus, and then we're gonna have this depression that the ball fits into. Okay. You're gonna have a bursa sac in here, and the bursa sac is going to provide some gliding for it. So it's not actually covering the joints; it's protecting the joints, like a pillow. Whereas the synovial joint itself is covering it, encapsulating everything, okay? So that is the difference between those ones. Like I said before, you have your bones, you have your long, you have your long bones, your short bones, very technical term there. Irregular bones, those are like the ones in your feet or your hands. Long bones, short bones, irregular bones, and flat bones like your ribs, scapula, things like that. So those are the types of bones that you have. And then again, for cartilage, you have hyaline cartilage, you have fibrous, think of discs there, and you have elastin. Either way, it's going to be ones that you can see that have a lot of ability to move. And of course, if you haven't figured this out already, cartilage is pretty much avascular. So slow healing times there, especially with your tendons, ligaments, things like that. Slow healing times with those because it doesn't have it. While it has blood supply, it doesn't have blood running through it the same way. So, anyways, very slow on healing time. Okay, let's go into the actual cells themselves. So the cells themselves, I'm going to just erase this. I think we hit pretty much everything we need to know here. Again, where bone and bone meets, that's articulation. There's cartilage in between there. You have compact bone, compact bone, which is much more dense. This is going to be more shock absorbent up here, much more dense, and this is going to provide structure. And you're going to see that, especially in the diaphysis. Because if I put spongy bone in your diaphysis, well, you're going to end up with being a broken leg. such is the case when you have osteoporosis. You end up having holes in your bones, and that's why it breaks. Okay, metaphysics, diaphysis. Yep, that is the gist of it. Of course, there's a lot more than that, but just to have a general idea of what we're talking about here. Okay, so the cells themselves, osteocytes, and again, site cells, osteobone, osteocytes. I spelled that wrong. I'm terribly sorry. All right, osteocytes are bone cells, specifically mature bone cells. And then you have osteoblasts and osteoblasts, which get very confused. But anyways, so osteoblasts are going to form. They're going to form bone. Okay, so they're going to use the calcium and the phosphorus floating around in your vascular system for bone to make bone. Osteoclasts, on the other hand, break bone. And of course, these are highly affected by your thyroid and things of that nature, but break bone. So when you think of clash, think of clash. So clash, basically, think about two people clashing together. All right, this is battle. He's got swords. He's got all right, so two people clashing together. That's going to break down bone. So osteoclasts break down bone. The osteocytes are your mature bone cells, and they're basically go in cylinders. So let's explain that for just a second. The cylinders themselves. So these are kind of like you might imagine a tree being formed. They're cells, and we're not going to go into the nuclei and all that other stuff. But basically, all you need to know is that they are in these circular structures, which blood vessels go through, and that's how the matrix looks. If we were to take a bone cell, so they're formed in rings, and blood runs parallel to these. The rings themselves, and again, there's a lot more to this, but rings themselves, okay. They get smaller and smaller. So basically, you have holes where your blood runs through. I don't know if you've ever ate like a chicken or like cut open a turkey and you see those holes in the bones. That's where blood is going through, or maybe nerves. But of course, they need to get smaller as you go through the bone. If you have spongy bone, then of course you have holes which all definitely go through. But in compact bone, you're going to need to make smaller and smaller holes to be able to make sure that you're getting blood delivered, or new cells coming out. So they get smaller and smaller. Eventually, I always remember cannolis, but they're not called cannolis. Or for the life of me, I can't even. I think they're cannolis. Anyways, the blood runs parallel to this. They're formed in rings. That's pretty much all you need to know for this. So that breaks down the bone. Again, not on the test, just something so you know. Osteocytes are mature cells. Osteoblasts make. Osteoclasts break. That's pretty much what you need to know. All right, so muscles. Muscles. There's three types of muscles. You have you have cardiac, skeletal, and then smooth. So your cardiac is only found in your cardiac, and it's actually a smooth and striated muscle. It has intercalcated discs, which are the only type of muscle that has it. The heart is really amazing. So this is an involuntary striated, smooth muscle. Again, intercalcated disc. If you were to be able to pick up a slide of this, there's no way that you can deny it being cardiac muscle. Your skeletal is, of course, voluntary, hopefully. Voluntary and striated. These are the ones like my bicep, tricep, any muscle that I can control. Smooth muscles are this in your vascular system, so your blood vessels, your organs. I cannot flex my spleen or my stomach, or I can't flex my small intestine. These are all smooth muscles. They're not within my control. Okay, my body controls them. So they're your visceral, personalized your heart, visceral organ, blood vessels, things of that nature. And a lot of times we have sphincters, like for instance, the bladder has a sphincter that's a smooth muscle, and then it has another sphincter, which is a skeletal muscle. So those are different types of muscles that you have. The muscles themselves, I won't get too far into it, but basically it works like this. If you could picture picking up like the way it was always described to me, and I think it makes the most sense, is if I were to take dry lasagna or a dry angel hair pasta and hold it in a ball, that's what a muscle looks like. So basically your functional unit of the muscle is a sarcomere. Myosin and actin work on the sliding filament theory. Boy, I can't say that word. And they connect and they pull together. Muscles cannot push. They don't push. They never have. So when you're doing a push up, it's not that you're pushing. Your muscles cannot push. It's that other muscles are contracting. So let's not get too far on that, because I could talk all day about that. But basically, again, back to I've got dry spaghetti in my hand. Okay. You've got little bundles. Let's see if I can't draw maybe all right, you've got little bundles, and in these little bundles, they get smaller and smaller bundles, okay? And we won't get too far into this, but basically it comes down to you have your sarcomere, which is the functional unit, and then you have your paramecium and your epimecium. Basically, it's just covering. So epi, of course, is always on the outside. You have to figure that out. And then let's make sure I spell this right. Mecium, and then your paramecium. And they're just like something that holds those bundles together, okay? So if I pull out this bundle, I'm going to have another little, piece of streaming spaghetti, but I could break it down farther and farther. Eventually, you could break it down to the functional unit, which is your sarcomere, and again, there's actin and myosin on, this is actually a theory, so it's not really proven, but they look like little striations, lines of actin and myosin, and that's your sarcomere. So, there's several different types of contractions. You have isometric contraction, isotonic contraction. You also have slow twitch and fast twitch muscles. Let me explain all of this quickly. First of all, you have, I suppose we'll start with contraction. So isometric, too easy, right? Iso is the same, the metric is a length. Same length. So if I go like this, and I'm holding my arm still, but I'm applying a pressure downward, all right, that is an isometric contraction. Contrary to what your book says, it does not create bigger muscles at all. In fact, that makes absolutely no sense. I have no idea who wrote the book. All right, so if you press down and I press up at the same time, I'm not creating muscle tearing, of course, unless I was under extreme, I can't even think. Anyways, so isotonic is the actual movement. So if I'm going to do a bicep curl, I'm going from here to here. That's isotonic, okay? So isometric, isotonic, same length. Really that means the same weight, but whatever. So this is not movement. If you can remember that part, then you remember the other part. So isotonic and isometric. You have atrophy and hypertrophy. Alright, so A without trophy. Alright, if you're without a trophy, then you're weak. Basically, that's muscle wasting. And then, of course, the other hypertrophy is hyper or big a hypertrophy, a big trophy. So you have bigger muscles. Um, Small muscles, big muscles. Too easy, right? Um, the book also is talking about slow twitch and fast twitch muscles. There is more than that. Just so you're tracking. That is also wrong. The slow twitch muscles are for slow twitch muscles are for prolonged use. Prolonged. This is if I tell you, hey, we are going to go on a 20-mile run at a 13-minute pace. All right, that is prolonged use. All right, if I tell you, I want you to sprint as fast as you can, or I want you to pick up this weight as fast as you can and push it over your head, that's a fast twitch muscle. All right, it takes a lot of work, and it's over and done very quickly. You run out of steam. So this is, I guess you could call it explosive speed. Um, you're calling on a lot of muscles here. All right. Prolonged explosives. So you have slow twitch and fast twitch according to the book. And again, just so you know, there's more than that, far more than that. But that's what you need to know, I suppose. All right. Sorry. So that talks about, so far we've got the different types of muscles, different type of cartilage, different types of bones, and the way that they contract. And again, a lot of that, as far as testing purposes, I've gone a little bit deeper than you probably need to. So let's just talk about quickly about how muscles communicate, or how the muscle actually works in involuntary. So basically, remember, we have the muscle here. This is actin, myosin, muscle. And if you haven't watched that other video, the movement of not electrons, the movement of electrolytes in and out of your muscles creates action potential. It creates electrical current, just like it would in electricity. Is creating electricity. Anyways. So at your motor end plate, so I have this, all right, motor end plate. Motor end plate is where the nerve meets the muscle. Now, you can have a nerve that controls many muscles. So you can call on more than just one. But anyways, the motor end plate, nerve where meets the muscle. The neuromuscular junction is between the axon of the nerve and the adjacent muscle cell. So this is your neuromuscular junction. And again, this is where this is the nerve, and this is the muscle. All right, and when it releases the stimulant down, it's going to make the muscle contract. So it releases calcium, and the calcium creates a contraction. So when calcium is what creates the contraction, and of course, if you have lack of calcium, you'll have tetany. ATP is the energy source that muscles use. So it's adenylyl triphosphate, and that could be quickly broken down if you use it very quickly, and it turns into adenylyl diphosphate, which can be replenished. But this is triphosphate di, so you've lost a phosphate in the process of your energy. So again, your muscles use ATP as a primary energy source, all right, and it very quickly will become ADP, and it lasts like absolutely no time at all. When you're, let's say you're gone on that 20-mile run. So when you've used up your ATP, which again, it goes through very quickly, you start building up lactic acid. And the reason why you build up that lactic acid is you have to go through a different process. But basically, you're not being able to use these reserves. So that muscle burning, that's lactic acid, and it's when glucose is low. And we won't go too much farther into that, but just so you know. Again, what you do need to know, ATP is your primary source of energy. Adenylyl triphosphate. You need to know that. Okay. The tendons, and here's how I remember this: tendons and ligaments. So tendons, T-bone steak. Here's your T-bone steak. Boy, that doesn't look like a T-bone steak, does it? Okay, so I don't actually eat steak that much. Anyways, we're gonna call this a T-bone steak because I think that's what it looks like. All right, so T-bone steak. T-bone steak, you have a bone in your T-bone steak. All right, so and then you have the meat, which is muscle. All right, so tendon attach muscles to bones. Muscles to bones. So think of T-bone steak. Ligaments, on the other hand, ligaments are going to attach bone to bone. So that's a bone-to-bone attachment. You're going to find this a lot in joints, things of that nature. One that is familiar to many people is your ACL, which is a ligament attaching your femur to the lower part of the leg, to the tibia. But anyways, ligaments are just attaching bone to bone. Tendons attach muscle to bone. So that's how I remember that one. And again, ligaments and tendons are very avascular. If they have blood flow, it's going to be very little. The fascia is a fascinating thing. The fascia is literally like one network. So that is interconnected throughout your entire body, and it wraps around muscles and different types of stuff, and it provides support and structure and fiber to your entire body. It goes around all types of stuff, and it also allows for gliding. I'm not even going to pretend to. It pretty much will look like a spider web, and it's fascia. And again, it doesn't really seem to have an end point or starting point. But it just holds kind of everything in there together. Think about it like entire glue all over your entire organs. Myofascial release, we relate to that a lot. But the fascia just acts as support, helps with gliding. There's some things where some diseases where you'll end up with holes in your fascia, such as the case in, and all of a sudden I lost the word for it. It'll come to me. Anyways, so fascia is just connected, and again, it's like one big old thing, and it connects in and out and weaves through different organs and all types of stuff. And that other word will come to me, but we already talked about bursa, and remember bursitis. So the bursitis is just the inflammation of the bursa sac, which is that synovial fluid in between your joints. Man, that's gonna kill me. I'll think of the word. Anyways, sorry. All right. So as you age, the biggest things, and again, this is pretty common sense, but I want to throw out a couple words. So proprioception. Proprioception is basically my awareness of my body and the world around it. All right. So proprioception. So it's a lot has to do with awareness of my body and spatial. So maybe I'll take a step and not realize that my foot is as large as it is or as small as it is, and I'll miss the step. And so it's just that awareness of your entire body. Of course, you're going to have a decrease in muscle mass, increase in adipose. And sometimes they don't have a decrease or increase in adipose, but you're going to definitely be starting to lose mass, muscle mass. Your CNS is not going to work quite as well, so calling on those muscles is not going to be the same. And as you know, you lose control of some of your skeletal muscles. So when we're going through the assessment, when we're going through the assessment, we need to be asking about different diseases. Diseases, which I cannot think of. It's going to come to me. So fibromyalgia. There we go. Fibromyalgia. They found holes in the fascia. They can't really figure out what causes it, but anyways. So fibromyalgia has the holes in the fascia. All right, I can let it go now. So history. We're looking for polio. Now, my grandpa actually has polio, but polio created muscle wasting. And of course, we don't hear about it anymore because we found the polio vaccine. But we need to know a history of polio, diabetes, which again is going to affect pretty much everything. High levels of glucose destroying vascular areas is never a good thing. And parathyroid, rickets, which is a deficiency. Again, we don't see it much here, but rickets. Parathyroid hormone. And of course, we want to know about that because it's going to affect your bone. We also want to know about certain drugs, NSAIDs, and so NSAIDs are going to have a huge part on, especially your renal system, but your NSAIDs. You're going to need to know about those. Your anti-seizure drugs. So some of those can cause osteomalacia, and your thiazides. So if you're taking a thiazide, corticosteroids are especially bad for burn. Corticosteroids are especially bad for bone breakdown. That's an anti-inflammatory, but they're especially bad for your bone. Excuse me. So potassium depleting diuretics. That's also going to have an effect, especially because potassium is intracellular. So when we have low potassium, that creates big issues. And those are some of the main things that you want to ask about. But definitely these corticosteroids, which are going to create bone loss. And of course, chemotherapy, anemia, vitamin deficiencies, and some medications just by the very nature are going to create muscle waste and bone density loss. So some other things that we need to do, active range of motion on arm. We have passive and active range of motion. So passive is basically I'm going to take not my arm, but the patient's arm, and I'm going to move it through different ranges of motion. All right. This is passive range of motion. Active range of motion is I can lift up my arm, and I could go different directions with it, abduct, circumvent, whatever. So that is the difference between active and passive range of motion. You can measure that in a geniometer. Make sure I spelled that right. John, what the heck? Okay, so basically I wish I had one, but it looks like this, and it's got 2 sticks on it, and you're going to be able to figure out, here's somebody's on, figure out the angle at which they can move it. So if I can only move it this far, well then I'm going to measure the angle right here. Scales of strength can range from 0 to 5. So 5 is going to be fully capable. They can push back, and of course it will decrease from there. So 0 to 5 as far as their muscle strength, being able to squeeze, being able to push, being able to pull on a force. The muscle measurement or your length. So if you have any gait disturbance, of course you want to measure the legs to make sure that they're the same height. Maybe if you have a breakdown in vertebrae or a breakdown in the meniscus or injury, then you might have, there's actually a disease too that we'll talk about, but different lengths is going to, of course, affect your gait. Now that straight leg raise gets talked about a lot. The straight leg raise, basically, if you're laying down like this, when somebody lays down, they're going to have an arc in their back. Maybe it can, okay. Well, when somebody lays down, they're going to have an arc in the back. So here's somebody laying down. All right, there's a natural curvature of the spine, and you're going to have this open space. Especially you'll see it on thin people. You'll have this open space underneath the small of your back. Well, when I take your legs and raise them up, it's going to make that flex down. All right, so it's putting the pressure on that spine to push downward when I raise the leg. So when I raise the leg, you can tell a lot of lower back issues from a straight leg raise. Of course, they're going to need to be supine, because here's my guy. They're going to need to be supine and go to 60 degrees or more. Some areas in your book are going to say something different. But 60 degrees with the leg itself, your foot is flexed at 90. Your foot is flexed at 90 degrees. Your leg comes up to 60. And if you experience pain, then it indicates lower back issues. L4 through L5, and I'll explain how to enable all that. L4 through L5. Or L5 through S1. Okay, so you go, okay, that's great. I can't even remember where L4 and L5 is, and we'll talk about that. And make sure if you're going to go and touch your patient or assess muscular strength, that your hands are warm, because that will prevent muscle cramping, twitching, things of that nature. So make sure your hands are warm to prevent that spasming. We already covered passive and active. And all right, so that goes over that. So let me talk about really quickly how I remember that O, C, and all of that stuff. And this is not in the book, but just so you're tracking, because I think it's helpful. All right, and actually, I learned this at a personal training conference, but whatever. All right, so we have vertebrae. We all know that, right? We have vertebrae. In between our vertebrae, of course, is that fibrous cartilage. Just throw that in there. These are irregular bones. But so C7, T12, L5. All right. So here's how I remember this. I eat cereal at 7. So at 7 a.m. I'm eating cereal. Now, just so you're tracking, there is, of course, your axis and several different bones attached into the base of your skull. So you have different bones there. But C1 through C7, I'm eating cereal at 7 a.m. Guess what? At tea time, which is noon always. At tea time, I drink my tea. So that's tea time's at noon. All right, and I'm gonna drink my tea. And guess what you have? Yes, you got it right. And of course, lasagna. So lasagna for dinner. And what time do we normally have dinner? 5 p.m. So this is how I remember that. And it helps out quite a bit. So, just so you're tracking. Okay, let's go through diagnostic studies, because that was hit on hard. And they really want us to go over the diagnostic studies. This, of course, is not completely exclusive, and it doesn't go over every single thing, but it's going to go over the standard ones. Okay, so standard X-ray, you can tell bone density from here. I just love it. X-ray. So you only need, when you hear the word contrast, is when you need to be checking for iodine. When X-rays, of course, I mean, you want to check for pregnancy. That's pretty standard. But not too much past that. You're going to be able to check for bone density, and of course, you don't want to expose yourself or the patient to unnecessary risk. So bone density, you can see it here. Now, you're not going to be able to tell something like you can in a CT scan, where you can see soft tissue. All right. So discograph, as it might sound, is going to be X-ray of your the lumbar or the disc, and contrast medium. Discograph. What did I say? Contrast. And that's in between your disc. Alright, so if I think somebody might have a herniated or ruptured disc or something of that nature, then I'm going to maybe look at a discograph, which has contrast in it. Automatically, contrast means we're checking for selfish. CT scan. CT scan is going to be able to give you the soft tissue. The patient needs to be able to stand still. So if maybe they need some pre-medicated individuals as necessary. So some anabolic something. So CT scan is 3-dimensional. You're going to measure soft tissue here. So if we're looking at, you need to look at the brain or the muscles. That's where I'm going to get this information from. Soft tissue, they just need to know that they're going to stand still. Myelogram, contrast into the sac of the nerve. It's going to detect lesions, injuries, head injuries. So myelogram, heart, myelogram, contrast. You heard me say it, contrast. All right, so there's contrast in the sacs and around the nerve roots. So we can watch the nerves there. So contrast. And there's a million diagnostic studies, so bear with me. MRI, again, MRI, and that's your magnetics. So jewelry, things like that, you need to be watching out for. Um, and making sure they don't have a pacemaker. The with the MRA, so just so you're tracking with the pacemaker. Pacemaker, of course. If I take a piece of metal that's not metal but magnet that is strong enough and put it over my pacemaker, it turns it off or affects it in some other way. Now I've talked to a couple of pacemaker companies because I randomly ran into reps, and they said it has to be directly on it, but you don't want to take that risk. So keep the magnets away from the pacemakers. All right, make sure you understand about any plates, screws, things like that they might have in there. Okay. And you're going to have the magnets going around. The bone mineral density. Bone mineral density is just what it sounds like. It's going to check the density of the bones. And bone scan involves injections of radioisotope into your bones. So we're checking bone for bone density. Bone scan, bone density. Again, radioisotope, but these are, just tell the patient, when people hear radioisotope, I said that wrong, isotope, they kind of freak out. But again, it's not enough to really cause any damage. Make sure your bladder is empty on that bone scan. Rethroscope. A rethroscope is basically exploratory surgery. Is that spelled? Rethroscope. Alright, when we heard the word scope, the minute we hear scope, alright, well, look at the prefixes. So we have arithro and scope. Basically, this is me taking a scope in, and it could be over a surgery or to absorb structures. Maybe I'm looking at meniscus, maybe I'm making a small repair, maybe I'm taking a sample. Either way, scope means small, puncture through, going through something, and of course, moving the bone. But so it's just an injection, and it can be used for small surgeries to create less damage, scar tissues, things of that nature. So those are some of them, and we've got several more to go through. Alkaline phosphate. So alkaline phosphate, you can use some of these tests. You're going to hear us say phosphate, calcium. We're looking at these tests to for a lot of times bone breakdown. So the alkaline phosphate, sorry, I'm not sure how this. All right, phosphate. So this is used by the osteoblasts of the bones. So osteoblasts, like I said, osteoblasts are going to make bones, but these levels are found high in fractures or anytime we have bone issues. So these are osteoblasts. Osteoblasts are going to have that alkaline phosphate. They're going to be using stuff like that. So when we have high levels, that indicates fractures or breakdowns of bone. So maybe osteoporosis, osteomalacia, osteoitis, breakdown in bone. Okay, so elevated levels is going to indicate a big breakdown in bone. There's also this Paget's disease. So Paget's disease, just so you know, and I had to look this up, but Paget's disease is basically where the bone's going to be broken down and then made somewhere else in some abnormal way. So it could be that my body decides it's going to extend its forehead, 6 inches in front of me. And it's just because the osteoblasts and osteoclasts are just doing what it wants. It's just building bone wherever it wants to build bone. Very random, very just all over the place. It seems to affect the legs and the forehead the most. But anyways, that's what Paget's disease is. And again, when we have a high level of this, it indicates some type of breakdown in the bone, or there was a breakdown in the bone. So your normal levels, just for you, so you know, for your reference, are 36 to 130. Nope, I'm sorry, 126 units per liter. The calcium, of course, we're going to measure. Because if calcium's low, we can determine possibly level of osteoporosis or hypoparathyroidism. Potassium, same thing. So potassium may indicate fractures. The RF, rheumatoid factor, that is an antibody. All right, so rheumatoid arthritis is a immune issue, not a external issue. It's a rheumatoid arthritis is a immune issue, and rheumatoid factor is an antibody, which is going to be linked to rheumatoid arthritis. And basically, it's your body's eating itself and messing with itself. Erythrocyte sedimentation rate. Erythrocyte sedimentation rate, as it might sound, erythrocyte is a blood cell. Sedimentation, that means settle down, coming to a rest, and the rate at which it does it. So basically, if I have blood within an hour, how fast are those red blood cells going to stop moving and settle down? And that is going to be high, and it has to do with inflammation here. So inflammation, if it's a high level, it can be related to inflammation. Again, that's back to rheumatoid arthritis. So rheumatoid arthritis or some type of inflammation process would be indicative of a high erythrocyte sedimentation rate. So the anti-nuclear antibody is exactly what it sounds like. The anti-nuclear antibody, and if we think about what we're saying in that slur of words, anti-nuclear is against the nuclear or the nucleus, and it's antibody. So antibody, as we know, is something that the body creates when either it has a reaction to itself or to a foreign substance. So let's say I have an immune issue and my body recognizes part of my normal structure as an antigen or something that it wants to build an antibody against and fight. So what is going to happen is I'm going to develop an antibody from that antigen. The anti-nuclear is going to destroy the nucleus of cells, and it's seen a lot in lupus and rheumatoid arthritis. And again, that's immune. So anti-DNA, geez, I wonder what that is. Anti-DNA antibody is going to react to the DNA, and again, lupus, because that's lupus and rheumatoid arthritis are immune. So lupus, anti-DNA antibody is seen a lot in lupus. The complete and total hemocrit. So complete and total protein is basically, complete complement. And there's a lot of different words for this, so I'm not sure why they use, anyways, that's okay. Complement, total protein. Basically, these are a bunch of proteins that work together for inflammation. It's basically C1 through C9, which we're not going to get into, but it helps with immunity. Of course, I'll have information, but it helps with immunity, specifically immunity. It helps with immunity. Bodies, antibodies against itself, and basically these proteins, when you find an elevated level, it indicates some type of immunity is going on. A lot of times that could be an immune issue itself, where the body's fighting itself, or you have some type of infection or something where it's creating that immunity again. All right, uric acid is protein breakdown, and this is in gout. Acid, that's purine breakdown again. Purines are found all over the place, in all types of weird stuff, but sardines come to mind when I think of purines. So uric acid is going to be that breakdown of the purines, and a buildup of it in somebody that's prone to it is going to create gout. So if you are not prone to having gout, your body doesn't want to produce it, then you could eat all the sardines you want all day and not have gout. So just to make that clear. C-reactive protein is an inflammatory disease. It's made by the liver, and it indicates tissue damage. So C-reactive protein. So basically, the C-reactive protein indicates tissue breakdown. The reason why it indicates tissue breakdown is because it's being used for creatine breakdown. So when you have your creatine breakdown, you're going to have this. But it's also an inflammatory diseases, all right? So you use it to diagnose inflammatory diseases, which of course is going to create tissue damage. So specifically tissue damage. So at the time, it might indicate tissue damage, which and the inflammation process of it. Of tissue damage. So human leukocyte antigen, and again, the leukocytes was blood cell, and antigen is something that your body recognizes as foreign or bad. And that's where it's linked to autoimmune disorders. So autoimmune disorders, lupus, rheumatoid arthritis, things of that nature. That Paget's disease possibly. Now they really haven't said whether or not that is genetic or not. So it doesn't seem. I looked it up. It doesn't seem like it's quite there. Anyways, seems pretty new to me. Human leukocyte antigen. So white blood cell antigen is something your body wants to fight, and it as it would, might imply, it's an immune issue. All right, so it's an immune issue. Creatine. So creatine kinase. There's also a couple different words for this one. Creatine kinase indicates muscle tissue breakdown. And again, creatine kinase, when that level is high, it means that the cells are muscle cells, or a lot of times be broken down. It's primarily found in skeletal muscles, but this is a good indication of breakdown of muscles or tissue damage, and that's because this is only found in your muscles, your brain, but primarily your skeletal muscles. So your creatine kinase, your body uses it to break down creatine. It's going to use a lot of ATP in this process. So when you have this floating around in your blood, you know that cells have probably been injured and have released this. So this is tissue damage, especially after a myocardial infarction damage or trauma. All right, so this is indicative of tissue damage, muscular damage specifically. Potassium. Potassium, we know it's intracellular fluid, so if potassium is floating around in your body, then, well, we know that we have an issue because cells are being smashed and killed, and potassium is escaping out into the body. Arthrocentesis. All right, so centesis, by the very nature of centesis, the word itself means to puncture. So you see thoracic centesis, it's a puncture. Arthro, again, bone. Centesis, I'm puncturing something and I'm drawing something out. So arthrocentesis, I'm puncturing something, drawing something out. A lot of times test fluids, synovial fluids, things of that nature. Electromyogram is the other one. Electromyogram is basically we're going to take all these small needles and stick them into your muscles to see if it's creating electrical current. It's supposed to be not painful, but apparently it is. It doesn't sound great by any means. But it's supposed to measure the electricity in your muscles, whether it's being conducted to identify muscular issues. The patient obviously needs to stay awake because we're testing skeletal muscles, which are voluntary. So if they're not awake, then we can't get the muscles to move. And that is going to wrap up chapter 62 in an hour nutshell.